All right. Hello, everyone. Welcome to a Mainstream Monday VMR. On these Mainstream Mondays, we get to focus on some bread and butter cases, which we can do on every other day of the week also. But Monday is a time where we really get to highlight some of the bread and butter cases. And I'm thrilled to co-discuss with the one and only Zakariyya, who is part of the VMR leadership team and just does so much behind the scenes at CP Solvers to help VMR keep running smoothly. And Zakariyya, just thank you for everything you do. And I'm so excited to co-discuss with you. Do you want to unmute and maybe share an update, how you're doing?
Yeah, hi everyone. Hi, Maddy. Thank you for the kind words, Maddy. I'm really excited for today's session. I'm currently on holiday, and it's amazing how about 2 weeks of not practicing medicine, and I already feel a bit rusty. So this will be a good way to keep my mind in the game. But excited
Yeah.
for this case.
What have you been doing with sounds like you've had some time off. What is the most fun thing you've gotten to do?
Yeah, so it's been Ramadan. So as is tradition, I reverse day and night, and I'm up most of the night. I wake up late in the afternoon, and I've been getting into AI coding and learning how to build websites. But excited for back to standard today.
Incredible. Wow, that's amazing. Building websites in your free time. That's awesome. Well, for scribing, we have Ramaswamy and Glenn. Would love to hear from both of you who are helping to make this session happen. Ramaswamy, do you want to go first? Maybe unmute and share how you're doing and what's going on in your day today?
Sure, yeah. Happy to be here. My name is Ram. Glenn was kind enough to kind of help me set this up, and happy to be scribing today. Happy to finally see warm weather on the East Coast, and yeah, looking forward to getting a run in later in the evening. But otherwise, good week.
Yeah, and Ram, remind me it sounds like you're on the East Coast. Where are you currently based?
Philadelphia.
Philadelphia. Awesome. All right, Glenn. Well, thank you so much for helping Ram with scribing. How are you doing today?
Hello everyone. My name is Glenn. Yes. So yeah, I'm a bit tired today coming from the hospital, but started to be doing the teaching points and started to contribute as much as I can.
Yeah, thank you so much for being here after such a long day in the hospital. That means a lot. And we have Daniel who's doing teaching points. Daniel, thank you for being here. How are you doing?
Of course. Hey everyone, I'm doing good. My name is Daniel, and I recently joined CP Solvers Academy, and this is my first time doing teaching points. So I'm really excited to be here.
Oh my gosh, that is such a big deal. Congrats on doing teaching points for the first time and for joining the academy. I'm so thrilled you're a part of the academy. And for those who have tuned in who are not yet a part of the academy, huge plug to present cases. And if you're a nerd like all of us and just like to learn and present cases, you will soon be invited to be a part of the academy. So huge plug to do that. And then, of course, we have the one and only Ravi who's presenting a case. Ravi, how are you doing today?
Oh, great. Happy Monday. Hope I also agree with Ramaswamy. Great, nice weather on the East Coast finally, so everything should be a-okay, hopefully.
Yeah. All right. Well, I think we can get started. So, Ravi, whenever you're ready, or actually Glenn or Ram, whoever wants to share their screen, go for it. Both of you should be co-host. Um, and then Ravi, whenever you're ready, you can share
Sure.
the first aliquot. And then Zachariah, if you're up for it, you can go ahead and tackle the first aliquot.
Sure.
So I sent Glenn the case so we can keep up with scribing. So today we have a 59-year-old male who is coming in with complaints of weakness, feeling cold, clammy, he's sweating, and he's having right upper quadrant abdominal pain. And he's 3 days post-op after having a VP shunt placed. And I'll stop there for discussion.
Wow, very, very interesting chief concern. And I think what I'm going to do is I'm going to start off with the initial symptoms you gave me of the patient feeling cold, clammy, sweating, and so on. Made me suddenly wonder if this patient was having any sort of reason to have a stress response. And even before we heard the symptoms of right up quadrant pain and him having had a recent procedure, I started to wonder, is there the possibility that this patient could have bacteremia? Just with the fact that he's being cold, clammy, is this patient potentially having rigors and so on? And then, very interestingly enough, you layer on that the patient has right upper quadrant pain soon after having a procedure. And I think I'm going to leave the right upper quadrant pain perhaps to Maddy, but just to discuss that potentially this could be completely unrelated. It could be partially the cause of the problem, or it could be the absolute 100% of the patient's chief concern now, the fact that he'd had a recent procedure. And if you think about it, if somebody's had a VP shunt, we know they've had a procedure from up in their cranial area down towards their belly. And could there be a possibility of seeding of some sort of organism from the CNS downwards? Or could there just be something that the patient actually had a procedure in their abdomen now and now has some sort of new infection or potentially other complication like bleeding and so on? So I'll leave the right upper quadrant pain specifically to Maddy because there's a bit of a bigger approach to that. But I'm very, very interested to see why this patient's had a VP shunt. Usually I associate that with the patient having had a raised intracranial pressure and something like hydrocephalus. And then I start to wonder, why does a 59-year-old male have right upper have hydrocephalus? Have they had any sort of trauma? Have they had any sort of subarachnoid bleed? Was there diffuse inflammation from something like meningoencephalitis that necessitated this? And I think also then just important that word weakness, could it just mean generalized asthenia, the patient not feeling well, or is it true focality? And potentially, do we need to emergently obtain further CT imaging to see if there's been a complication of the shunt or some sort of new sort of infarction or bleed? So very excited to hear Maddy's approach to right upper quadrant pain, but a fascinating start to the case.
Zakariyya, I just wanted to just applaud you for truly some amazing teaching right there. And one of the things I really love that you did is, you see the current constellation of symptoms and this crucial past medical history, the fact that they had this very significant procedure 3 days prior. And I really love how you outlined the fact that, of course, in probably all of our minds, we're thinking, could this be some type of complication from the VP shunt? But I think you did a really great job of stepping back and not immediately making that assumption and kind of holding in your mind the possibility that it is possible that these new constellation of symptoms could be true and unrelated to the previous procedure. But I totally agree with you that kind of in real life, when you have a big procedure like that and you have symptoms in very close proximity, probably in your mind, you should be thinking, could this be a complication until proven otherwise? And I love how you anchored us in kind of what is a VP shunt in the first place. And exactly as you said, basically you have this kind of implanted device that goes from the brain's ventricles into the peritoneal cavity. And exactly as you pointed out, usually my understanding is that that's for hydrocephalus, exactly as you pointed out. And so I love that you asked the question, why does this person in their 60s have hydrocephalus? I think we should absolutely get to the bottom of that. But then to your point, could there be a complication of that, whether it was seeding of an infection or malpositioning of this device? Other things that I'll add to your fantastic discussion is two things. So the fact that Ravi told us the patient was feeling cold, clammy, and sweaty, to me, I'm translating that to a concern for possible shock. So immediately I'm wanting to know, what are this patient's vital signs? What is the blood pressure? What is a lactate? And is this person in shock? And we need to go down that route. I think for the right upper quadrant pain, of course, when you have some type of localization with abdominal pain, you can kind of think of the organs in that location. So what is in the right upper quadrant? You have the liver, you have the whole hepatobiliary system. But because all the organs in the abdomen are, kind of squished together, you don't want to just anchor on that, especially when someone's had a device in their peritoneal cavity. So I think, I'm thinking about, could this be a localization to the liver or to the biliary system, but definitely not anchoring just on those organs, especially because he's had this procedure that's involved the abdomen. So maybe I'll pause there and turn the mic back to Ravi to hear more.
Absolutely wonderful discussion. Yeah, these are things that we see. Complicated VP shunts come to the emergency room. We do admit them. So We do get freaked out a bit when we do see this, but we can have medical issues that you've talked about above. So he 3 days ago he had this shunt, he was discharged, then he started feeling bad, went to this other hospital, then transferred back to this hospital for further workup. He also mentioned he had dizziness, he had fallen a day prior as he tried to walk. And whilst he was coming in, he also had a very elevated heart rate. Heart rate was 130s to 140s, but he has a history of AFib in the past. And he's noted in the ER to be confused, and his temperature is 101.6. His past history, as you asked, why did he get the shunt? So he has NPH, and he had shunt placement because of this. Hypertension, BPH, OSA, AFib, and hyperlipidemia. And medications, he's on atorvastatin, HCTZ, lisinopril, Eliquis, diltiazem, and oxycodone. I'll just wait for the scribe to catch up. And then the other history is nothing remarkable. We'll just sort of skip that and sort of cut to the chase, and I'll give you the exam. All right, so yeah, temperature was 101.6, heart rate 132, blood pressure 113/80, respiratory rate 18, pulse ox 98% on room air. Neurologic exam was normal, generally on room air, was ill appearing, and respiratory was unremarkable. The only remarkable finding was the abdomen. There was right upper quadrant tenderness. The abdomen wasn't distended, no guarding, no rebound. There were bowel sounds, no edema, no skin abnormalities, and I'll pause there for discussion.
Zakariyya, if you want, you can take this aliquot and then I'll add in after you discuss.
Oh, why didn't you start first this time?
Absolutely. Sure. Okay, so and Robbie, one clarifying point, just wanted to, was his mental status, was there also kind of altered mental status and confusion as well?
Yeah, he wasn't somnolent, but he was like disoriented.
Okay, and then any like nuchal rigidity at all?
No.
No, nothing like that. Okay. So, here, what's really standing out in the vitals is kind of his fever and his tachycardia. I'm seeing that his blood pressure is in the normal range, but I think given how tachycardic he is right now, I'm worried that his blood pressure, he could be, that may be temporary and that he may be in impending shock, just given how fast his heart is having to work to compensate. So I think when you have a fever, you translate that into inflammation. And with the acute time course, really the focus is infection right now. And so in my mind, the exercise I'm doing is where could be the source of infection. With the right upper quadrant tenderness, I think I'm most concerned that there's an infection in the abdomen. And I think there's, a nidus of infection with this recent procedure. And with the kind of localization to the right upper quadrant, some things that I would not want to miss are some things like acute cholangitis, for example. So I think right now I'm worried that this person is infected, and I'm trying to think, where could he be infected? The abdomen is definitely, I think, highest on my differential. But the reason why I was asking about the confusion and kind of the nuchal rigidity is I'm also wondering, do we need to be worried about CSF infection as well, especially because the VP shunt, there's been instrumentation into his in his ventricles and in his brain. The fact that he doesn't have nuchal rigidity is helpful, but I think I'm not fully putting that hypothesis to sleep yet. I think if we find an explanation in the abdomen and the confusion resolve or kind of improves with antibiotic treatment for the infection in the abdomen, that would be helpful. But I think right now I'm still entertaining, could the CSF be infected, and or is the abdomen infected? I think, practically what would I do in this situation? Of course, it would be helpful to kind of see the patient in real time to get an actual sense of what they look like in their mental status. But I probably would be, until I have more information, because I'm concerned about an infection in the CSF, I probably would be sending the workup and starting empiric antimicrobials for that until because of the mortality of that. And so practically what I would be doing is I would be sending blood cultures for, suspected meningitis. You can give like IV dexamethasone before you get a CT scan of the head, and that helps to reduce complications. And then I think I would likely be starting empiric antimicrobials for meningitis and then kind of peel them off once I get more information. And just to kind of go over some of those, the empiric antimicrobials that you give when you are suspecting someone with meningitis is you give vancomycin, ceftriaxone, and then for certain populations you give ampicillin and acyclovir. Just to kind of quickly go over why you give those. So you give ceftriaxone for Neisseria meningitis. You give vancomycin for the possibility of ceftriaxone-resistant strep pneumo. You give ampicillin for listeria, and you give acyclovir for HSV. I'm wondering, that's kind of generally the antimicrobials that I've learned that you cover. But when you had like a recent procedure, I'm wondering if those need to be tailored in some way to cover things like MRSA and Pseudomonas. And so in those cases, you'd probably want to use like ceftazidime, which would have MRSA coverage over ceftriaxone. So you see kind of what I'm doing here is basically I'm worried about infection in the head, worried about infection in the abdomen, would want to cover broadly, and then as we get more information, peel back. Zachary, I'm curious if you're thinking any differently about this or what.
So the patient was
where your mind went after all this data from Robbie.
No, wonderful thoughts, Maddy, and very little to add. I think the one thing is I completely agree with you that this patient needs empiric meningitis cover. I remember quite a memorable case of I had a young female that had fulminant idiopathic intracranial hypertension. Her intracranial pressures were in the hundreds, and she actually became temporarily blind. And then she'd had a shunt placed, and then she came in with, I would say, a mild to moderate diffuse abdominal tenderness. And I've been quite certain that she had peritonitis as a complication of it. But she just had sort of bystander abdominal pain, maybe post-procedure, and actually the entire source of her presenting to the hospital, all the infection was actually completely up in the CNS, and she had actually TB meningitis in that case. So in addition to the infection potentially in the brain, the other thing not to miss is the fact that the patient is disoriented and we don't know what the shunt is doing right now. So I really think this patient needs immediate CT imaging, because we need to see, has the shunt dislodged? Is it not working and become blocked for some reason? Sometimes shunts can actually overshunt and they overdrain, and you get something, I think it's called slit ventricle syndrome, where your ventricles actually get really small, and that can also cause neurological symptoms. So just to make the point that shunts can malfunction in ways besides infection. And then just to add on, in terms of the infection, I think the one thing for me would be the fact that if this patient just recently been in the hospital and they've had a procedure all the way down to their abdomen, would they need sort of something that would cover hospital-acquired gram-negative infections in terms of meningitis, which is not normally the case. You rarely see gram-negative meningitis, but in this sort of situation, I wonder about that. And I think just the last thing is that the sort of classic triad for meningitis, even in a standard meningitis, is rarely seen, and especially with a VP shunt-related infection, you have a shunt that actually goes into the ventricles, and so it's not directly at the meninges. And in addition to that, the source of infection then might be around the catheter itself and not the meninges itself. And that means that, yes, you will have some meningeal inflammation, but most of these patients will not have full-on nuchal rigidity and so on. And I think just the fact that the patient has a fever for me would be enough reason to go for meningitis. So I think very worried about this patient, and I'd be shocked if there's any sort of answer in the blood work here. I'm sort of expecting a high white cell count, a high CRP, and so on. And I think really, if we could get some CSF fluid, that would be telling. And then I'd be so eager to see what the imaging shows. So please tell us more, Ravi.
Well, absolutely wonderful discussion. This patient would be well served by the both of you. So moving on to lab data that you requested, white cell count was 16.39, predominantly neutrophils, hemoglobin 11.2, platelets were normal. And then looking at chemistries, just the abnormal, the AST was 75, ALT was 46. And FOS was low, 2.2, a little bit low. Albumin, 3.2. Total protein, 6. And the rest of the electrolytes were normal. EKG showed AFib with RVR. And the CRP you asked, Zakariyya, 351. And unremarkable, X-ray was unremarkable for pneumonia, and viral panel for the respiratory viral panel negative, which was done too. UA was negative, and I'll stop there. Actually, MRSA nasal culture was negative too. Blood culture is negative, and then I'll stop there and I'll give you the next piece of data, which will give you the diagnosis.
I think all I would really say here is that everything we're seeing in these bloods is sort of expected, and even instead of pertinent negatives, I think we were worried about the possibility of something like cholangitis, and it's interesting to see that the cholestatic markers are normal. I think in this situation, with the fact that the patient has right upper quadrant pain, and we have a good reason to suspect that there might be some sort of infection in there, is that this might be somebody who, if they are not getting better very quickly, I might actually repeat these liver enzymes fully 6 to 12 hours later instead of waiting the next day if we feel like there's a possibility of worsening. Because if you have an acute obstruction, your AST and ALT can rise first, and then the cholestatic markers come about 24 hours later. And it's possible that, for example, if this patient had the early stage of acute cholangitis, you'll do these bloods now, and if you repeat them 12 hours later, you'll have an AST and ALT in the 600, 700 range, as they can rise very, very quickly. So just to not make the mistake of thinking that the AST and ALT are slightly abnormal, probably not something to focus on. They might be a clue to the patient's underlying process, or they might just be the fact that the patient likely has some sort of sepsis-related ongoing inflammation, and it might just be a complete bystander. Yeah, and I think very eager to see what the imaging shows. But anything to add, Maddy, to that?
No, Zakariyya, I thought that was a brilliant analysis, and I agree with you that I think I still would want, probably in real life, unless the patient looks very different from what I'm imagining right now, I'd probably still investigate the hypothesis of CSF infection. But I think, especially with the right upper quadrant localizing pain, a CT scan of the abdomen, I totally agree with you, is the next step from that perspective. I think one quick teaching point is the AFib with RVR. I think it's the way I've learned to think about AFib is basically the equivalent of sinus tachycardia. So kind of asking the question, what is usually a compensatory response to something? And so here, I think the way I'm thinking about the AFib with RVR is that it is a compensatory response to the underlying infectious process that they're having. But agree with you that abdominal imaging and would probably be the next step for me.
Okay, wonderful. So I don't have the whole CSF, but the white count was elevated in the CSF at 32, and a CT was done like both of you had requested. The CT abdomen pelvis showed enteritis, gastroenteritis. I think there probably some dilated loops of bowel, but nothing pathological, nothing abnormal with the with the liver. Antibiotic-wise, because a patient had returned back from healthcare facilities, so they had to entertain healthcare-associated infections such as MRSA and Pseudomonas and other MDR gram-negatives. Linezolid and Zosyn was started, but linezolid was discontinued once the MRSA came back. And from the CSF, the cultures grew Klebsiella aerogenes, which was sensitive to cefepime. And infectious disease was involved. They recommended removal of the shunt and placement of a temporary external ventricular drain, and to monitor the serial taps for infection clearance. And then once the CSF cultures are clear, and then the plan is to proceed with removing the shunt and then eventual replacement. And I'll stop there.
Wow, Ravi. And you said it was Klebsiella aerogenes, is that right?
Yep.
And so this was basically meningitis, kind of second from Klebsiella, and we're thinking of this as basically a complication of the placement of the VP shunt.
Right.
Yeah.
So you both of you had the diagnosis from the get-go that there's something in the brain and the patient has an infection. And I'll give you a few points after you guys discuss.
Yeah, I think first of all, Ravi, just thank you for bringing this really, really important case. I think it allowed us to reflect on when someone has had a recent procedure and is coming in, especially with symptoms of inflammation. Really, your working diagnosis should be that this is a complication from that procedure, probably until you're proven otherwise, and especially when you have someone febrile, really kind of looking at where could the infection be. I think it allowed us to think through kind of the workup that you get when you have someone with suspected meningitis. And so that workup is getting blood cultures. And I learned from Robbie that the yield of blood cultures is usually 50%. And then you can get, give IV dexamethasone and then imaging, and then ultimately want to get an LP. And I think Zakariyya taught us, when thinking about the antimicrobial coverage, when someone's been hospitalized, really the additional organisms you want to think about is could MRSA be at play, could Pseudomonas be at play, but then Zakariyya also taught us, do we need to think about some of the gram-negative organisms as well? And that's kind of ultimately what was found here, the Klebsiella aerogenes. I'll have to look up I have not personally seen kind of Klebsiella in CSF, so I wonder if that's a bug that's kind of unique to some, when you have instrumentation in the brain. But I'm interested to look that up. Zakariyya, I'm curious, any reflections that you have?
Yeah, I think, honestly, for me, the first reflection is brilliant discussion, Maddy. And the second thing I think I wanted to say is that Mondays, these cases are called Mainstream Mondays. And I just really don't want people in the audience to think that Mainstream Mondays are sort of simple bread and butter regular cases that are only meant to be presented on Mondays, because we come to VMR not to learn about familial Mediterranean femur. Yes, that's cool and so on, but we ultimately come here to enjoy, have fun, but also to learn about things that we will see every day. Because a great doctor isn't somebody who will diagnose familial Mediterranean fever. It's somebody who won't miss a pneumonia, who won't miss a meningitis, and so on. And so if you look at all the teaching points on the board that Daniel's going to outline, we come here to learn about fever, to learn about tachycardia, to learn about AFib, to learn about liver enzymes. And the point of these Monday sessions is to highlight this so that you can see how much learning can be obtained from sort of simple cases. And so I encourage all of you, if you have cases that you feel that are too simple and that VMR is a place only for the rare, that's really, really not the case. And even if you have that simple case, if you put it through artificial intelligence and you discuss and say, help me present this case in an interesting, unique way, we can take any simple case and really get the most out of it. So please bring, as we keep saying, we want cystitis on a Friday VMR, and I hope this case highlights that.
Absolutely. I wanted to highlight one other fantastic thought in the chat. Lyra mentioned a great point about basically AMP-C risk with Klebsiella aerogenes. And so there are are certain bacteria that basically possess this something called like AMP-C, which I think is a gene that can get turned on. But basically, it for those specific organisms that have this AMP-C gene that can be expressed, those organisms are resistant to specifically to ceftriaxone, I believe. So you'd kind of have to look at the susceptibilities of the Klebsiella aerogenes, but I think specifically for that organism, you would not want to treat with ceftriaxone and would want to treat with a different agent because you just assume that they would have the AMP-C gene. So I think that's a really fantastic point, and thank you, Lyra, for bringing that up. Ravi, do you want to share kind of, I'm not sure if you personally saw this patient, but what you took away from the case?
Oh no, it was one of our morning reports, but I sort of cut to the chase at the end. You guys already knew what was going on, but I think in real time you do have to have sort of an open stance to what could be going on. Looking at just the data that was taught to me by the resident that presented this case, so the incidence is 5 to 15%. Usually will occur early within the first 2 months, especially the first month. In this case, it was the first 3 days. Usually it'll be stuff on the skin, so like Staph epi, Staph aureus. Gram negatives usually less, but you can see it. Say you have a prolonged hospitalization, if there's abdominal contamination when you're placing the catheter, say the patient had a trip to the ICU, or they've had a ventilator-associated pneumonia or other nosocomial sources. Now, what was interesting, there was this liver enzyme elevation, which sort of could deviate you off your primary course, which was thinking CNS infection. So that I don't know why that happened, but if you think about it, it could be that it may be just a downstream effect of the infection, and you get a little irritation of the liver enzyme. So it's a very mild elevation, and it resolved. However, you have to have a suspicion if this does get worse. What if this, like you had mentioned, Maddy, that the shunt goes down into the abdomen? Could this be an abdominal complication of this VP shunt? So you got to start, you got to get that CT scan to look if there's anything happening with the shunt near the liver. Sometimes we also see it could be due to drugs, or it could be something totally different. Maybe patient could be manifesting with cholecystitis and having a simultaneous diagnosis happening at the same time as well. And if you do, I think Zakariyya mentioned some of these complications. I think you have to know, and when you have a patient like this, what could be the complications of a VP shunt that's placed? So he did a wonderful discussion. What if you have a malfunction and you have under drainage or over drainage? So those are two things to think about. Infection is one of them too, and then just the malposition. So you do want to do imaging to see, is it positioned appropriately, or has it deviated off its course? And then the last complication would be abdominal complication. Is it going and poking somewhere and causing physical trauma on something as well? And sometimes an outcome of this could be seizures as well in these patients. So I think VP shunt, we have meningitis. We do have cases with meningitis, but then sandwiching it with this VP shunt, I think was important in highlighting and teaching everybody about these devices. And great discussion. Thank you for discussing this.
That was phenomenal teaching, Ravi. Thank you so much. Yeah, I think we haven't had too many opportunities to talk about complications of VP shunts on VMR. So a really important case to bring, and thank you for that teaching. All right, Daniel, mic to you for the teaching points.
All right. Amazing case, guys. So we have a 59-year-old male with non-pressure hydrocephalus status post-VP shunt with an acute presentation of right upper quadrant pain and confusion, found to have a fever and other signs of infections. So the first teaching point was upon further questioning, we found that the patient had cold, clammy, and sweaty. And we were suspicious that this can be some type of stress or a sympathetic response. And this is important because it can tell us maybe the situation is emergent, if it's possibly due to like a shock or a possible bacteremia. Then we went to the next complaint, which was a right upper quadrant pain, status post placement of a VP shunt. So we had two different branches of hypotheses. First is some related to the surgery, and this can be infections in the abdominal area or bleeding or malpositioning of the device. And then we also mentioned we should also consider those not related to the surgery, and we can take an anatomical approach to that, and we can consider the organs in the right upper quadrant. But also it's important to also consider other organs in different quadrants because everything in the abdomen is like squished together. There's also, upon further investigation, we found fever and tachycardia. And this could be a sign of acute inflammation, also considering the time course. So here we're suspicious of an infection. And whenever we have an infection, we want to start localizing the infection. And we're thinking this could be because of their chief complaint and VP shunt placement recently. We're thinking, okay, abdomen or the central nervous system. Afterwards, we also found that the patient was disoriented. And whenever I think of disorientation or altered mentation, is some type of sign of brain dysfunction occurring. So here, considering that and the VP shunt placement, we're also very suspicious of meningitis. And Maddy and Zakariyya mentioned that we should have a low threshold for treatment in cases like this because complications for meningitis can be very serious. So they recommended giving the patient steroids and also empiric antibiotics, including the ones listed over here. And then also we should consider gram-negative coverage too, due to a hospital-acquired infection. And then also made some recommendations to continue to investigate with blood culture, CSF culture, and CT. Upon further investigation, we found elevated ALT and AST. And this can be due to many reasons, including like sepsis or an abdominal complication. A point Zakariyya mentioned was, so just because even though the ALP is normal, the ALP could have a delayed increase in cholestatic diseases. So we could, if the patient does not improve, we might need to check labs again to check for cholestatic markers. Another interesting point I really liked was with AFib with RVR, the comparison to sinus tachycardia. And when a patient with AFib has RVR, there's most likely an underlying cause. So it's important to really investigate and see what that cause is. So the diagnosis turned out to be Klebsiella meningitis due to a VP shunt, secondary to VP shunt placement. Some important or some interesting learning points for me was that it can present atypically. Seems like the many shunt infections could have like a biofilm around the catheter, and that might lead to like an atypical presentation where the patient might not have like nuchal rigidity. And another important point was that these infections could usually present within 2 months after shunt placement. Amazing case, guys. That was really, really awesome. Thank you, Maddy, Ravi, and Zakariyya for the amazing presentation and discussion.
Oh my gosh, I need to shout out two people in particular. Daniel, you, and first time doing teaching points, that was absolutely stellar. Just the way you organized it and focused on some of the high yield points, really fantastic job. That's very impressive. That was your first time. And I also need to shout out Ram, who was his first time scribing along with the help of Glenn. And in my opinion, scribing is probably one of the hardest jobs in all of VMR. And you made it look effortless. So thank you both for doing that and for doing it so well your first time. All right. Well, thank you, Zakariyya, for co-discussing and Ravi for a case. And thank you all for tuning in.
Thanks, everyone.